What's up, everybody? Welcome to today's episode. Today, we're talking to guest speaker Kristin Mallon from FEMGEVITY Women's Health Initiative. Now, her and her partner, Michelle, have created this awesome environment to really get in the trenches with women, meet them where they are in their current health journey, and help them break down step by step where to go next to really gain the most optimal health that they can. Now, I just think Kristin is a wealth of knowledge. Every time I talk to her, I am more impressed and I want to keep talking to her. She teaches me every single time we have an interaction. And I am so happy that we are working with her because we really couldn't find anybody to help us the correct way. I didn't trust anybody. Now I give my endorsement. I trust her so fully. She is really about finding optimal health in every way, shape, or form, not just shoving a bunch of hormones down your throat or a prescription. She literally takes your microbiome test. She takes every type of blood work test that there is and gets down to the nitty-gritty and figures out how to optimize you individually. This isn't just a mass blanket prescription. She really gets in the trenches, like I said, and provides women with the optimal hormonal health that they've never really experienced before. Now, if this is something that you are interested in, I highly recommend working with Kristin. I'll leave links below in the description. If you also are interested and you like this conversation and you want to hear more, I will be doing more of these conversations and podcasts and interviews. Just like, subscribe to this channel. And without further ado, let's jump into it. Well, welcome back again. Thank you so much for doing this again. I'll just touch on that briefly. My computer updated and it deleted our entire first conversation. So I hated it because I went back through and listened to it 2 or 3 times because I loved it. It was great. It was exactly what I wanted. So now we'll just refine that, do it one more time. And I really appreciate you doing this again.
Great. Yeah, no problem.
Can you just give a brief intro again for who you are and or what your company does and who they are?
Yeah, I'm Kristin Mallon. I'm a board certified nurse midwife, and I've been practicing OBGYN for 20 years. I co-founded a company called FEMGEVITY Health with Michelle Wispaway, who has an MBA, and she has been in the diagnostic lab space for the same amount of times that I've been in the field of women's health. And FEMGEVITY Health is a telemedicine platform for women who, I mean, it's really a feminine longevity platform. It's longevity health for women, but a big part of that is hormones, hormone balancing, perimenopause, menopause, and postmenopause healthcare. And that's a lot of what we do. And we do that on a daily basis. We also do a lot of functional or integrative or longevity medicine, whatever name you have, testing. We do gut microbiome testing, genomic testing, allergy testing, cancer screening. So we do a lot of like what's the up and coming, the most up to date from the diagnostic lab space, and then also from a women's health space. We're really not looking at healthcare as, you know, sick care, crisis care, critical care. We're looking at it as the optimization and optimal healthcare, and that's what we're offering for women.
Almost like putting all your eggs into prevention and optimizing so that you don't have to depend on the cure.
Yeah, exactly. Yeah. So it's really about health optimization. So it's not even just about being healthy, but it's about being optimal.
Optimize. So with that being said, can you re-enter the Women's Health Initiative back 23 years ago? Can you restate that again so women can really understand where this whole hormone replacement therapy went wrong for women?
Yeah, so the Women's Health Initiative had a study that was published in 2002, and it was one of the largest studies for women. Actually, interestingly enough, there was a larger study done a couple years before with 30,000 women. This study had 27,000 women, and it was evaluating the efficacy, the safety, the health benefits, and the health risks of HRT. And primarily, the real goal was about estrogen. And is estrogen cardioprotective? Is it good for bone loss? Is it, you know, they were looking for all these different health benefits and also risks. And what they found was that they had 2 arms of the study. They had one arm of the study that had estrogen and a synthetic progestin called methoprogestin acetate, or MPA. And they had a second arm in the study that had just estrogen alone, because it's kind of been long known that back before this study, estrogen was kind of seen as this like key to immortality. And if women just take estrogen forever, there was this book that was written called Femme Fatale. And it was basically like estrogen is going to solve all of your health problems. And in a lot of ways that was true, but in a lot of ways that was not true as well. And then they did this estrogen arm of the study, estrogen only, because the thought and the consensus at the time, which really isn't no longer the case anymore, but that if you don't have a uterus, you don't need progesterone, because the only reason you take progesterone is to balance out the estrogen. You don't want to have unopposed estrogen for a long time, because if you have unopposed estrogen, unopposed meaning no other hormone to balance it out like progesterone, then you're going to end up with endometrial cancer. So they had one arm of the study that was estrogen only for women that didn't have a uterus, and they had another arm of the study that was estrogen and progestin, the synthetic progesterone. And what they found, what the study actually really found, was that women in the arm of the study that had the estrogen and the progestin had a very, very small, slight increased risk of breast cancer that actually some statistical models say isn't even significant. So it went from 3 in 1,000 women to 4 in 1,000 women. So when you look at that, it looks like it's a significant increase because you're going from 3 women to 4 women. But when you look at it over 1,000 women, and when you look at it over multiple thousands of women, they weren't even really sure if the statistical significance was enough to say that it made an effect. And then what happens, we can see that it was the progestin estrogen arm of the study that had the increased risk of breast cancer. They published in JAMA, in a very big, one of the biggest articles in the world, the biggest health journals in the world, that estrogen causes breast cancer. There was a big issue with the study. They had 30 principal investigators in the study, and only 3 of them actually read the study. The other 27 just signed off on it without actually reading the study.
Great.
The New York Times ran a whole bunch of articles about how estrogen causes breast cancer, which is actually false, because interestingly enough, in that study, they found that the estrogen arm, the women who were taking estrogen only, the women that didn't have a uterus, had a lower incidence of breast cancer. Their breast cancer incidence actually decreased slightly, also probably not statistically significant. So not only was it false that estrogen caused breast cancer, the study actually found the opposite, that it decreased a woman's risk of breast cancer. Yeah. And then that halted the study of that. I mean, that halted the use of estrogen overnight, literally one day to the next, which in medicine, we never do that. Whenever someone comes out with a finding, we always try to replicate it and make sure it's true and make sure there wasn't other factors in the study or there wasn't bias in the study that caused that to come out that way. But they were just like, we have to halt the use of breast cancer, or we have to halt the use of estrogen because breast cancer is way too dangerous. We can't take any risks. And literally overnight, women were pulled off estrogen. I remember, so I was in school at the time when this happened, but I remember like hearing about women coming into the clinic and women coming into health offices and being like, I was totally doing great and I was fine and I had a management of all of my symptoms. And overnight, my doctor called me on the phone at home and was like, you have to stop taking your estrogen immediately. And that just has never, ever happened in the history of medicine ever. And then the long-term sequelae of what is the impact of health on cardiovascular health and the impact on health with bone health and cognitive health and dementia is pretty profound and probably pretty significant. I don't think we really understand exactly the harm of not using estrogen, what that's caused this generation of women from 2002 until now, because now women are starting to be more comfortable using estrogen. I don't think we'll really know the depths of what harm has actually come from it, but that's kind of what happened 22 years ago. And women have been confused and clinicians have been confused ever since about estrogen and progesterone and progestin and the safety and what's really causing breast cancer and what's really not. And then one more thing I'll say about it. I know I'm kind of going on along about it.
I love this. You go on all the tangents you want because you are the professional and you get so detailed. I love it.
It's such an important event that happened in women's health, this study. Yeah. But, 1 in 4 women is going to die, or sometimes people even think 1 in 3 women is going to die of cardiovascular disease, whereas only 1 in 8 women are even going to get breast cancer. And breast cancer has a 90% positive prognosis rate. So it's, we've come so far. I think in women's health, we've come so far in so many things that we have to pat ourselves on the back with. We've come so far with miscarriage care. We've come so far with fertility care. We've come so far with breast cancer. But there's these huge elephants in the room, which are cardiovascular disease and Alzheimer's and cognitive decline and dementia and menopause that are kind of being left in the lurch. I mean, I could go on. I think PCOS is being left in the lurch and endometriosis and adenomyosis. I think, we're overusing hysterectomies. So I'd love to see what we've applied to breast cancer in such a positive and impactful and wonderful way, and what we've applied to miscarriage care and fertility care to these areas of women's health too.
So do you think that that's just pure incompetence because you said they didn't even read the study, or is there malicious intent in that? Or do you think that's just under competent people running those studies?
I definitely don't think it's maliciousness at all. I mean, I like to give people the benefit of the doubt, but I think I think what happens in medicine a lot,
Yep.
and I see this even now, I work at a pretty large hospital in New Jersey, and it's, one of the top hospitals in the country. And there's still that mentality in medicine of we
Yeah.
do this because this is the way it's always been done. And we do this because my mentor told me we do it this way.
Yep.
And that's very pervasive in medicine. And it makes sense because your mentors are smart and intelligent and they've been in the field for 20, 30, 40 years and they have all of this information. And I think research is helpful, but I also think research is really behind.
Yes.
It's usually anywhere between 5 to, I would even say 25 years behind
Yep.
what clinicians at the bedside know. This is like off topic, but it's so interesting. Like one of my really good colleagues really believes that preterm labor is caused by cervical insufficiency. It's not caused by like random idiopathic, we don't know what happens. It's caused by it's a cervical issue. And that our practice has a preterm labor rate of less than 2%, where the national rate is 10%, 8%, 12%. And so the way we screen and treat cervical incompetency and cervical insufficiency, we're onto something there. And the research isn't even touching that yet. And what's going to happen is eventually that's going to come out. And then 25, 30 years later, we're going to be like, I can't believe we let women miscarry at 20 weeks or, have miscarry at 20 weeks or have preterm labor at 28, 32 weeks when we had practices like ours 25 years ago doing the right thing. We've been doing this for probably 15 years, and the research isn't even starting to touch that issue yet. And so I think similarly, we have all of these other things in women's health that are the same, which is why I think people put so much value on what their mentors tell them and what clinicians that are older than them tell them, because people that are at the bedside doing this day in and day out get it. So it's hard to say, my mentor told me estrogen causes breast cancer, like to go against that.
Got you. Yeah, I was just telling you last time that I was listening to this podcast, and one of the medical directors was saying that at any given time, his estimate was the textbooks that they are learning from and reading from are 15 years behind.
Oh, yeah. Yeah, I totally believe that. Or more, even, I would say.
Yeah, like you said, to 25. I believe that.
I mean, look at the example that we just talked about with the Women's Health Initiative study. It's been 22 years, and we're just now starting to crawl our way out of that after 22 years of misinformation and being behind.
I feel like a broken record when women are going, yeah, but why would I need that? Da, 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 all this stuff. And I said, listen, you don't even, man, here, check this study out. And they read it and they're like, yeah, they said that the findings were that it promotes cancer and you can't do that. And they don't understand the bioidentical versus the synthetic hormones. Can you just touch on that briefly of what that means?
So this is another kind of theory where I think medicine is behind, and we're just starting now to kind of come to the surface on this. But so in that WHI study, the estrogen progesterone arm actually had Premarin, which is an estrogen we don't even use anymore. That's an estrogen that's made from horse urine. And it also had a synthetic progestin. So we don't even use those hormones anymore. And the synthetic progestin that was used, and that if you think about it, if you really look at the study, that was the arm that had this very slight increased risk of breast cancer, the estrogen and progestin arm, where the estrogen arm had a decreased risk in breast cancer. That progestin is what's in IUDs, it's what's in Mirena IUDs, it's what's in synthetic birth control. When a woman goes on a NuvaRing or she goes on a pill or a birth control pill, that's the same type of progestin that's used.
Yeah.
And the estrogen is also a synthetic estrogen as well in birth control and in a lot of commercially available products. So that progestin is now starting to come out that it's linked to breast cancer. So we knew that 22 years ago with the Women's Health Initiative study. And there was just an article this week in the New York Times about how the Mirena IUD, which is a progestin, synthetic progesterone, is linked to potentially an increased risk in breast cancer. So it's not confirmed. And again, I don't want to alarm people and be like, well, now Mirena's IUDs are causing breast cancer, because we don't know that to be true for sure. But we just kind of have to like really dig deep and look at all the information. So when we're doing menopause and perimenopause treatment, we're using bioidentical hormones. So we're using hormones that are very, very, very similar, just a few carbon atoms away from what a woman's body naturally makes. Now, the reason why we have to use progestins in birth control is because progesterone itself is like the sand of the hormone system. It's the sand of the sex steroid cascade. So when you give a woman progesterone, it doesn't stay progesterone for very long. It turns into cortisol and testosterone and DHEA and estrogen and all the different sex steroid hormones that a woman needs. The building blocks are really cholesterol, pregnenolone, which is another hormone, and progesterone. So the half-life of progesterone is really short because it's getting turned into something else. So you can't use progesterone, the actual bioidentical progesterone, in birth control because it's not going to prevent ovulation or prevent pregnancy. You have to use a synthetic progestin, which has a much longer half-life, which is why we have synthetic progestins in use at all. Because people are like, well, why don't we just use bioidentical progesterone? And it's very similar. We know this about other hormones like thyroid and insulin. So insulin is a hormone, it's a growth hormone. And when women had diabetes, in the early 1900s, they were given porcine, pork insulin or bovine insulin, insulin from a cow. And that worked pretty well. But when we were able to synthetically make bioidentical insulin in the lab, now insulin is one of the most bioidentical hormones that we can make because we've been making it for so long and we've perfected it so well. And there's been a lot of money going into the use of insulin. When a woman takes that type of insulin, her body responds immediately and instantaneously and much, much better. And she's able to get so much better glucose control with a synthetic bioidentical insulin. I mean, it's hard to say because it's bioidentical, meaning it's like what she makes, but it is made in a lab.
Yeah,
So
but it's very, very close compared to synthetic.
just a few carbons off. I mean, we're talking, and I think they're even getting, I think
closer.
they're even getting what they're calling them biosimilar now, which it's like one carbon off or like carbon identical.
Gotcha.
And the same thing was true for thyroid. So women that had hypothyroidism and they used the same thing, bovine and porcine, pork and cow hormones to replace the depletion that they had in their own thyroid hormone. That worked good. It worked better than nothing. But then when we made synthetic levothyroxine and we made Synthroid, which is a bioidentical hormone, it's bioidentical to what a woman already naturally makes, the control was so much better and so much pure. And so why wouldn't that also be the case for sex steroid hormones as well when we talk about estrogen, testosterone, and progesterone?
Gotcha. So yeah, I wanted to touch on that birth control one more time here. You really laid it out last time with the delaying of the birthing process and how it was really messing up women as they would have menopause, premenopause, perimenopause, etc. Can you go into that again?
Yeah, so
like evolutionarily also?
Exactly. Yeah. So we don't know why, and you and I talked about this a little bit, like we don't know why women are the only mammal in the world that at midlife, the ovaries, they die basically. That organ dies, it goes through its own death, it stops functioning, it stops producing sex steroid hormones. The other organs, the heart, the kidneys, along the brain, they all have the same trajectory as every other, like a male human and other mammals that are very close to us, bonobos and chimps. Women also are the only mammal, not our closest relatives, the chimps, that go through the loss of fertility at midlife. So we don't, I think about this at night in the shower when I'm sleeping. Why did this happen? And the best guess I can come up with is it was some sort of virus or mutation or something that happened, some environmental factor that happened that just mutated women's bodies to, I mean, we know what happened with a drug like DES in the 50s and the 40s, like how that impacted generations later. And there's something called Fragile X syndrome, which is affecting generations later and later. So to me, that had to have been something that happened like that. And so why is it happening to women? We don't really know, but there's something we can do about it, which is replacing these hormones. We know when we replace these hormones that women are losing at midlife, they have longer life, they have better morbidity, they have better mortality, they have less cognitive decline, less Alzheimer's, less dementia, less brain fog, they have better cardiovascular health, and they have better bone health, and they live longer and they live better. So why? We don't know. The other issue that you kind of talked about and that you kind of wanted me to touch on is we always kind of say like, well, this is natural, this is natural, this is natural, but we don't live in a natural world. Yeah. We live inside, we have electricity, we have indoor plumbing, we have an abundance of food, we have an abundance of carbohydrates. That's not really natural to how our bodies evolutionarily were built. We're still like very behind. We haven't evolved as fast as our society has evolved to the type of living that we have. We're very communal and we did things a lot differently. And when it comes to reproduction and it comes to women's health issues, we were really meant to have 50 periods, maybe 75 periods in our lifetime. And women are having 400 to 500 periods in their lifetime because we were meant to get pregnant as a teen and then be breastfeeding and pregnant for many, many years and have 8 to 12 children and have those long periods of space in between when we were breastfeeding and not have that many periods. And so when we have this overproliferation, we're having more menstrual cycles than our bodies were really designed to handle. That's why we get things like endometriosis, adenomyosis, PCOS, ovarian cysts. We get all of these things because we're not meant to cycle every single month for years and years and years and years and years. And birth control, I have like a love-hate relationship with birth control.
Yeah, we do.
Birth control does, I mean, it's great because you get to have agency over your body and your fertility, and you can control when you want to have children or when you don't want to have children. And it's doing a really great job because you're still cycling every single month, but you're not cycling as high and as low. So it's hibernating ovulation. And so you're not having these extreme proliferation of the uterus and an extreme shedding of the uterus and extreme proliferation. It's much, much milder. And so it does something to protect women, because we do know that women who use birth control, and birth control is a therapy and a remedy and a treatment for endometriosis, PCOS, and a premenstrual syndrome, heavy bleeding, adenomyosis, all of these things that come up in women's health, birth control is used to treat. And women that use birth control in the long term tend to have higher rates of fertility in their 30s. And they also tend to have less complications from the gynecological system in general as a whole. So it's, 6 dozen of one, half a dozen of the other. But and I think why companies like FEMGEVITY Health and a company like mine is needed is because we are the indoor plumbing and the electricity and the wearing of shoes and the driving of the electric cars of women's health. Like how we got here, we're not really sure. Why we're here, we're not really sure. But there's so much that can be done to support women. And yes, it's natural to die and it's natural to go through menopause, but you don't have to suffer. You don't have to go through it where it's ruining your mental capacity. It's increasing atherosclerotic disease and plaque buildup in the heart, and it's causing you to have insomnia and mental decline and cognition decline. You absolutely can, but you don't have to.
Yeah, I know the birth control topic is really big. A lot of the women that I asked to ask questions had that question, and they're like, well, we don't know what to do. We think it's correlated. I read these studies, it's correlated to more cancer, less infertility, et cetera, et cetera. Here's the thing. Do you think it's just being pushed too quickly I know right now, a few of my female clients, their 13, 14, 15-year-old daughters were put on it for acne control. Do you think that's reckless, or do you think that is... You know what I mean? It's a very hard area to navigate.
It's totally hard to navigate because it's a best friend, it's a frenemy. And I think for better or worse, it is most OBGYN's go-to tool for treatment, therapy, and remedy because it is so well studied and there's so much that's known about it and there's so many options. There's so many ways to tweak and control and manipulate birth control. I mean, we just can't. I think one of the things that women don't like to hear, and it's not so popular to hear, is that we just can't get around the health benefits of having a pregnancy before the age of 21. Women who have a pregnancy before the age of 21 have like a 7 times reduction in breast cancer. And we know that's because they have, when a body is exposed to HCG, human gonadotropin hormone from pregnancy, even if it's for a short period of time, just a couple of weeks, it halts breast development. Because it's the body's way of learning from the environment. Like, oh, I'm of reproductive age now. Like, I'm mature enough to now reproduce. I don't need to continue my breast, ovary, uterine development. Wow. I can halt that development. And so we don't have this overproliferation of dense breasts and dense breast tissue. We just find healthier breasts in women who have had, even if they had a pregnancy for a few weeks and then something happened to the pregnancy in their teen years. So we can't get around that. And I don't think the solution is women are going to now have pregnancies in their teen years. I mean, that's the natural solution. Yeah. So we have to come up with these unnatural, synthetic, technology-driven solution, and birth control is one of those, because birth control, especially if you do extended cycling with birth control and you have a period every 3 months or every 4 months, now you're really protecting your uterus from overproliferation. You're having a reduction in endometrial cancer. You're usually having a reduction in ovarian cancer and ovarian cysts, and you're definitely having an increase in fertility later in life, and you're having a decrease of all of the reasons why somebody is using birth control to treat women for menstrual cramping or acne or, any of the other common things that women report. So is it reckless? I don't know. I really don't believe
it's 50-50, right? Like,
yeah. And I don't really,
it's correlated sometimes, but it's not, we can't point the finger and say it's causing these type of cancers, XYZ.
Exactly. And I think that, I'm kind of a big believer, and I really do believe that the teen years, especially 15, 16, is really meant for a woman's body to kind of work out what's going on from her reproductive cycle. Yeah. And, I kind of really do favor more birth control in the later teen or early 20s time. I'm also a really big fan of mixing it up, of not being on the same birth control method all of the time, and letting the body have periods where it's having natural cycles and periods where it's having, not natural cycles, and kind of having a woman try to get as in tune as she possibly can and as in touch with what she's experiencing, what she's feeling, and what she's going through to try to help her navigate that. And I am a big proponent of early pregnancies. I am. It's just really healthy for women to have pregnancies if their lifestyle and their life whenever women are like, I'm not ready, I'm like, earlier, the earlier the better. I'm like, the
Yeah.
earlier the better. Like, do it now. Don't wait.
Yeah, but like you said, I told you this quote last time from this evolutionary psychology book, and they said we are built perfectly for a world that no longer exists. So this is birth control is our option in this new world, this new society of delaying birth and figuring this out. I've never heard the cycling type of situation, how you just said, like the protocol of maybe you go on, you go off. It also comes down, I know it's controversial, but it comes down to having men and women both having sexual discipline and kind of understanding, like that's what we're going to teach our daughter, is trying to understand the rhythm of her menstrual cycle early as possible. And just so she can, I know still we have to figure out a situation because you don't want a 16-year-old having a child and when she's not ready in her life. But yeah, okay, great. I want to move right on from that. Thank you so much for that detailed explanation. I wanted to touch on the real big factor here that you see all the time, the primary care, right? Saying the you're within range, you went in and got your blood numbers. Ashley, myself, I would challenge these women and or men to go to their doctor and even ask for hormonal testing. And they would go and ask, and their doctor would question them why they're trying to get their hormones even checked. And then on top of that, they finally, after they've begged and pleaded, get that test back. And the doctor says, yeah, no, you're within range, sends them an email, says you're within range. Why does that happen? Can you kind of explain how the lab system works like that? So why someone's always falling in the middle, or maybe they're at the end. When we first had Ashley's done, she was at 1 point below the lowest you could do, or above the lowest you could be on the test. And her doctor literally wrote her a message saying, looks like you're fine for a 34-year-old female who works out every day, is in great health, XYZ. And then we were like, she's like, but I feel like shit. So can you kind of like just explain the optimizing of that and where that the ranges come from? Because a lot of women don't understand this, and a lot of new women into this type of hormone replacement, etc., they want to know from a doctor what that really is, what that means. How come it keeps on landing in the middle or somewhere in there and they're within range and okay?
Yeah, so I think it's a lot of things. Primarily, I really like to let OBGYNs and primary care doctors off the hook because I don't think it's right as a society. We're putting too much on OBGYN. So one doctor that goes to school, they do 4 years of medical school, 4 years of residency, and now they're an OBGYN. They're expected to be an expert in pregnancy. They're expected to be an expert in complicated pregnancies and gynecological issues and ovarian cancer. And what you see, just like what happens naturally, is most OBGYNs specialize. So you have some OBGYNs that go into childbirth and they do a lot of pregnancy, delivery, labor and delivery, postpartum, prenatal. You see some that go into gynecological surgeries. You see pelvic floor specialties. Yep. You see breast health specialties. So it's just not realistic to expect an OBGYN to be a master in everything. So then when you're coming to, and the same thing with a primary care doctor. I mean, a primary care doctor is women's health and everything else, and brain and heart and kidneys and lungs and liver. When you come to someone who in their health panel, like I always say, like, you want to see somebody for hormones that in their docket of patients that they're going to see in the day, half of them are hormone patients. And when you go to an OBGYN, when you see, usually like 75% of those patients are pregnant. So you're going to get, and then it's 25% of ovarian cysts and endometriosis and maybe one hormonal patient a day. So obviously that provider isn't going to be that well-versed in looking at labs from hormonal patients day in and day out, constantly, and being like, okay, I'm starting to see trends in my mind and I'm starting to understand patterns and do pattern recognition. So I think a lot of times they don't want to do it because they don't know how to read it. And that's not anything bad on them or any fault to them. It's just, they physically cannot be an expert in all of these things. So I think that's what's happening there.
Yep.
Secondly, the labs are really telling you, do you have a chronic disease? Yes or no. So they're not telling you, are your labs optimal? Yes or no. They're telling you, do you have Cushing's disease? Do you have Addison's disease? Like that's what they're looking at when they're looking at testosterone and DHEA and cortisol levels. So you get the labs back and it's like, oh, you don't have Cushing's. You're like, okay, but I still feel awful.
Yeah.
So that's why working with a hormonal expert. So somebody who has looked at hundreds and hundreds and hundreds of women's labs and worked with hundreds and hundreds of women, knowing that, well, your one lab value is X, that's still within not disease, right? So you don't have a disease, but you don't have optimization of your health and you still don't feel 100%, you don't feel right. And even certain labs have different ranges as well. So you can have a lab in California that's going to tell you that a thyroid level is 5.0 is normal. Okay, you don't have hypothyroidism with that. And another lab in New Jersey that's telling you, well, 4.2 is high. So there's no consensus from lab to lab. And then on top of that, we know, for example, in hypothyroidism, it's just been studied a lot more than, because men have it too, I think, than in women's health hormones, that if you have a TSH of 4.2, it's going to come up normal in a lab. You have subclinical hypothyroidism. You have a disease. You have a disease process in the works, and maybe it's in the early stages of the disease process, but you need thyroid support if you have a TSH of 4.2. So that's kind of, I think, what's happening. And that's why it's really helpful to work with a hormone expert. And, that's why we started FEMGEVITY, is because that's why we're doing it telemedicine, is because women don't have access to people like us and the clinicians that work in our field. So then we can have clinicians that work in one state treating someone in a different state, so women can have access to this type of care and the type of analysis that they're looking for in their labs.
Great. Yeah, I mean, it makes total sense. So it does fall on the individual to seek out that specialist, because you're expecting to be the all in every situation. I was just reading this about relationships, and they were saying you're expecting that partner to be your friend, to be your lover, to be your intimacy partner, to be your parent. Like, you're expecting all of this when you should not be putting that type of weight on your partner, because they can't be all of that at once, just like a doctor can't be all of that at once.
Right, exactly.
Yeah, that's what I was gonna, I had another thing. Oh, can you go into how important, because this is another big issue that needs to be clarified for women, how important, and the book that you recommended last time, testosterone, is for women, as well as estrogen, and how cardioprotective estrogen is, because we had that question last time.
Yes.
You detailed it so perfectly. I'm so sorry to make you do it again, but I really want to hear everything you have to say about that.
Yeah, that's okay. So the testosterone is, I think we have a hypotestosterone epidemic in women, and for a lot of different reasons. So testosterone gets a bad rap. Testosterone is associated with bodybuilding. A lot of times women are like, well, I don't want to take that. I don't want to have huge muscles. I'm not trying to look like I'm in a bodybuilding contest. Like, I just want to feel better. Women have 3 times more testosterone than men. And at certain points in their menstrual cycle, they can even have 10 times more testosterone than men, like around ovulation, which is why women tend to have more of a desire and an arousal during that time in their month. It is such a valuable and important hormone. And for the same reason, so we don't know why hormones peak in the early 30s, and then from the early 30s into the late 30s on start declining. And testosterone is one of those hormones. And because of different genetic markers, actually, some women will actually lose testosterone much earlier than others, and some women will hold on to testosterone much later. And so you can have this mix match among women, where some women are like, oh, I'm having my, we try to have women a free testosterone for women. And testosterone's great because it's one of those hormones that you can measure pretty well with blood work. We really want them to fall within the upper limits of normal on a lab test of free. So we're not really worried about total.
Free.
Because that's not what's bioavailable. We're looking at a free. And we see women, so most labs will run you even 0.1. They'll say, oh, it's normal. They have a little bit of testosterone. It's normal.
Yeah, you're alive.
So it's
You're
normal.
alive.
Yeah, you're alive. Yeah, you have a heartbeat. And it can go, in most labs all the way up to 4 or 5 for women. And we want women around 3 or 4. That's kind of usually the happy place where most women feel really great. And we find women constantly all the time at 0.1, 0.2, 0.5, 0.4. And they're having all of these very classic symptoms of low testosterone, which is associated with low desire, low motivation, low libido, but testosterone is related to dopamine. So it's going to have all of these other issues that go along with pleasure seeking, that go along with being motivated, the deep fatigue that women feel when they don't have enough testosterone, not just the desire for sex, but also the desire and the zest for life. Most women who have low testosterone feel incredibly depleted and tired, around 3, 4, 5 o'clock in the afternoon. They have a lot of muscle aches, joint pain. I'd love for someone to do a study about the diagnosis of fibromyalgia or malaise, because I think that that's related to low testosterone, probably because a lot of times when we have women that have muscle aches, muscle pains, bone pain, joint pain, and they go on testosterone, they feel a million times better. Yeah. And the same thing with lower abdominal weight gain. So when women have that lower abdominal weight gain, it is associated with you got to get the hormones in the Goldilocks range. Too much estrogen, you're going to gain weight. Too little estrogen, you're going to gain weight. Too much testosterone, you're going to gain weight. Too little testosterone, you're going to gain weight. And it's the same thing with hair and hair loss. Too much testosterone, you're going to lose hair. Too little testosterone, you're going to lose hair. Too much estrogen, you're going to gain hair with too much estrogen usually. But it's so overlooked. And I think it is a pervasive epidemic. And I think it's, again, one of these things where people that are in my field and in the hormone balancing field and in the perimenopause and menopausal field, we're again, 20, 25, 30 years ahead of the studies. I think we're going to come back to this, and your daughter and my daughter, it's going to be like, oh yeah, everybody does testosterone, everybody does hormone replacement, everybody does bioidenticals, or some equivalent. There's going to be, there's a lot of really cool technology that's talking about ovarian freezing and removing pieces of the ovary and replacing them and using your own ovary as therapy. I mean, let's hope that therapy is true and works and comes, for our daughters, but it's going to become a big thing. So there was a woman who wrote this book called The Secret Female Hormone, and she was an OBGYN, and she had low testosterone levels herself. And then she was like, her life was changed. And she was like, I can't believe as an OBGYN, I'm not telling people to look at this, look into it, think about replacing testosterone. Her name was Kathy Malpin, and it's called The Secret Female Hormone, How Testosterone Replacement Can Change Your Life. And
Bingo.
It's just amazing. The other thing that I think women need to know about testosterone, because now you're going to have the naysayers about testosterone, is that testosterone is not FDA approved for women in the United States. It is FDA approved for women in Australia, and it is even available over the counter in Australia. But in the United States, there is still a stigma about giving women testosterone. And that's something that women who take testosterone are going to have to come up against. It's interesting because we're in a lot of states. We're in Florida, New Jersey, New York, Texas, California. And I think it's cultural. In Florida, everybody wants testosterone. Everybody calls us, get me on testosterone. I want testosterone. The women who are 30, 40, 50, give me testosterone, give me. And then the women in New Jersey are like, I can't take that. That's for men. And, so I think I really encourage women, like, definitely think about testosterone, research it, read this book, get your levels checked, talk to an expert. And if you decide that it's right for you and you decide to go on it, like, do it. We support you, and just know that there's going to be those naysayers out there that are going to tell you it's bad, it's wrong. We know testosterone is safe. There have been many, many studies that testosterone is safe. And the worst thing that's going to happen to you usually is you're going to get some, male issues. You're going to get hair loss. You're going to get, acne. You're going to get chin hairs. You're going to have a little bit of rage, and you're going to have a little bit of anger, and you're going to have, maybe like clitoral enlargement and a deepening of your voice. It's not killing you. It's not harming you. It's not doing something where you're going to have these like long-term, never recover, types of symptoms, because we're not doing, sex changing levels of testosterone. We're just doing testosterone support, little tiny whispers of help and support for women to have access to testosterone in their bodies.
And even with you saying those possible worst outcomes possible, right? The worst case scenario, you have to be on testosterone for a long period of time and or a elevated dose without leveling it out to have voice deepening or the whatever else, the hair loss, etc. It's not like when you go on it, you're going to have to deal with that and lose your hair and have deepening voice and all these things. That's where you come in, correct? Because you are facilitating the right levels of the testosterone, estrogen, progesterone, and whatever else that you were prescribing.
Yeah. And that's why, working with a hormone expert is really helpful, so that you can have someone that holds your hand and kind of like walks you through it to be like, okay, this is what's normal for you. Continues to check up on your levels and continues to make sure that you're not too low and not too high. I mean, unfortunately, we're trying, it's just like taking insulin. When someone takes insulin or takes thyroid replacement hormone, if you have too low, it's a problem. And if you have too high, it's a problem. So it's this constant evolving evolution. I believe, and there are people who are working on these products. They're not available yet, but where you're going to be able to, like how you can test your luteinizing hormone when you're ovulating, and you pee on a stick and you stick it in a machine, you stick it in a little computer, and it's like, okay, luteinizing hormone is this much.
Yep.
There's another company called Miracare, which has the same type of testing for estrogen and progesterone. So you are able to do the same thing and see, okay, what is my daily estrogen, daily progesterone? Because these are daily hormones and you're taking them daily. So it's going to be
fluctuating, correct?
So helpful to have that information. And then eventually they're going to make one for testosterone too. And that level of data is going to be like what diabetics are getting when they wear an insulin pump, or what people that take thyroid replacement and they get their labs checked every 3 months, from their endocrinologist. That's going to be super, super, super helpful, so that we don't even have these highs and lows anymore. But, it's coming. It's just,
it's behind. Yeah, we're not here yet. Especially with AI coming, I'm very hopeful for that, because we can process a lot of data and get a lot more knowledge out to people quicker that way. The other piece of the puzzle that I wanted to just touch on as well is how protective the estrogen is, the correct levels of estrogen, and as well as, I mean, you talked about all of that in my field of the body and training and all of this, the anatomy. Like I said last time, 80% of osteoporosis is from women, of bone degradation and osteopenia and or sarcopenia. So it's like your muscle mass and your bone density are one of the top health span factors, especially if you're a woman, because you don't have the muscle mass that a man naturally has. So that is one of the biggest pieces, because we see that over 65, one of the biggest risk factors of death is falling and
Yes.
fracturing your bone. And then you're in the hospital and you pick up a disease and you can't recover because your muscle mass and bone density is decreasing every day you're in the hospital in the bed.
Yeah, so I think I saw a study one time that if you're over the age of 74 and you have a large bone fracture, your chance of dying in the next year is like, over 50%.
I
Like
saw
some
that.
very high number.
Yeah.
But yeah, so I mean, estrogen, and this is why if you go, I mean, in some ways, you can understand what happened. Like we started out here, where you and I are now, this is where we started out with femme fatale. Like we knew estrogen was a magical drug. It is.
Yep.
And then we came into the WHI, and then the pendulum swung completely the other way. And the truth is in the middle somewhere.
Yeah.
But for cardiovascular health, I mean, estrogen is so cardioprotective due to its influence on cholesterol and triglyceride levels and its interaction with lipids. And so it reduces atherosclerotic plaque and it reduces atherosclerotic buildup. We actually have women in our practice come off statins when they start estrogen. Eventually they usually do need to go back on them. And I'm not saying like take estrogen instead of a statin. That's not what I'm taking at all. But it is an alternative. And a lot of really avant-garde and new age cardiologists are using estrogen themselves to treat women for cardiovascular disease and for cardio prevention. And, if you have a significant cardiac history, estrogen is going to be so much more beneficial to you than even a pretend theoretical risk of breast cancer. The other thing is you talked about bone health. So for bone health, it helps to promote the activity of osteoblasts and which are bone forming cells and prevents bone reabsorption. So it helps it prevents the bones from breaking down and degrading. And we know this because women who are on estrogen long term, and we have women who are on estrogen into their 90s, these women do not have osteopenia, osteoporosis in the same levels as their counterparts do. We also know that when a woman stops estrogen, because that used to be the leading theory that you take estrogen until you're done with menopause and then you stop it sometime in your 60s, that the bone loss after the stopping of estrogen is dramatic and drastic. Wow. And that's when you have a significant loss in just 1 year when you stop taking estrogen. So we already know all of these things. It helps with the brain and cognition. It's neuroprotective. It supports cognition function. It helps to maintain synaptic plasticity. It prevents women who are on estrogen have lower rates of cognition decline and Alzheimer's and dementia. It also helps with metabolism and insulin sensitivity. It helps with skin health. It helps with vaginal health and prevents vaginal dryness. And it has a significant effect on mental health too, because of its effect on neurotransmitters, serotonin specifically, and then dopamine for testosterone. And it has a significant mood stabilizing effect. It helps with endothelial function. I mean, it's just
everything.
Endless what it can do, which is why, that book, Femme Fatale, that book will make you believe that estrogen is going to solve all of your problems. But, it was written in the 60s and
it's a piece of the puzzle.
Exactly.
It's a big piece of the puzzle.
Yeah.
That was and you were saying that heart disease is the #1 killer of everybody, let alone women. It's I don't know what the men's is, but that doesn't matter right now. And you're saying that estrogen is cardioprotective, so that you actually are helping, let alone all of the things you just said, you're helping the #1 cause of death in women, balancing the correct amount of estrogen.
Yeah, I mean, it's believed that 1 in 2 women, so 50% of women are going to have cardiovascular disease at some point in their life, and it's going to kill 1 in 4 women. Wow. It is the #1 leading cause of death for women. So just that alone is a reason. And people always ask me, what are the risks of taking HRT? Like, so certainly if you've had a history of a DVT or a cardiovascular event like a stroke or a heart attack, or if you've had an issue with pulmonary embolism, you are not a candidate for estrogen. Outside of that, most women can take estrogen safely, even women who have a history of breast cancer themselves, yes, and women who have a family history of breast cancer. Because I hear that all the time, like, well, my mom had breast cancer, so I can't take estrogen. And I'm like, no. That's not necessarily true. We don't want to give women estrogen who are on tamoxifen, who are actively in breast cancer treatment, but it is safe for most women, and then it's going to significantly increase their life long term. And so people ask me, well, what are the risks of estrogen? But I always want to say, well, what about the risks of not taking estrogen?
Not taking it, yeah.
Exactly, because that is not talked about nearly enough in our field, I don't think, at all.
Yeah. I know we're running close on time here, so I just got to pull out a couple more things here. Remember the dirty air filter analogy we were talking about? Or you had the roof analogy, right?
Yeah.
That was a good one. So you don't just do hormonal only health and optimization. You do everything down to the gut microbiome, which controls, that is the epicenter of everything. Can you just kind of go through real quickly that, as well as, I know it's so long, we talk forever, but the phytoestrogens and the difference of like how we're getting so much synthetic phytoestrogens, it's throwing off our body. We're not getting the correct amount and the correct bioidentical estrogen, which is causing this massive over influx of fake estrogen, synthetic estrogen from lotions, creams. I'll let you take the floor on that.
Yeah, so I think you're talking about something really important, which is so two things. One is the power and the benefit of cleaning out your system, cleaning out your gut, making sure there's something in the gut called the estroblome. And the estroblome is basically how, and every day studies are published about this. It's so fascinating because like if I wait too long and then I go back to the research like a month or two, I'm like, oh my gosh, there's this study and this study about how the gut microbiome, how certain type of gut bacteria like biobifidum and Akkermansia, and how certain enzymes found in the gut like zonulin and secretory A and beta-glucuronidase affect the metabolism of estrogen specifically. Now, I believe I'm going to infer that if it's affecting estrogen specifically like that, it's probably also affecting testosterone and progesterone, which are like incredibly important sex steroid hormones for homeostasis and the maintaining of optimal health for women. So we're just now starting to understand how the gut affects the metabolism of estrogen. So if you're not clearing estrogen from your gut properly, you're reabsorbing old estrogens. And there's more than 20 different types of estrogens that are found in the body. And there's even, I mean, this is probably a topic for next time, to be continued for women that want to know about specifically about the betas and the alphas and the 17 hydroxys of estrogen that are linked to breast cancer specifically and where they're coming from and why they're getting into the system. But a lot of it has to do with it's not getting cleared, it's not getting excreted in the gut. And that's where, especially for women who don't want to take a lot of hormones, they can clean up their gut, clean out their liver, clean up their diet, clean up their home, get rid of the phytoestrogens or the pseudoestrogens, which I'll talk about in a second. And then they actually,
health, right?
Exactly, they actually need less hormones. They need less hormone replacement. So usually we find that so 80% of women are going to need hormone replacement. And I don't think it's fair. We talked about this last time too. Like there are the 20% of women that don't need it, that aren't having any symptoms, that aren't having the effects, that don't have the issue with lower abdominal weight gain, insomnia, night sweats, mood changes, mood destabilization. They're not having the issues with the inability to put on muscle mass. For whatever reason, genetically, the virus that got us hundreds of millennia of years ago didn't affect them in a negative way, or whatever reason. Genetically, they go through menopause, 20% of women, where they don't need anything. They don't need any hormone replacement, and everything kind of works out really well for them. These women are on social media and they're telling all these other women, well, you can just do it like how I did it. You can just exercise and eat right and supplement and do Pilates and yoga, and you're going to have a menopause like me. And it's just not true. It's true for 20% of women, and for 80% of women, it's not true. So for women that would benefit from and could be helped by hormone balancing and hormone replacement or hormone support, they tend to need less the cleaner their diets are. You know, we have women in our practice who are vegans and acupuncturists and, you know, exercise gurus and nutritionists, and they all get to 80% of them get to that point where they're like, I've done everything I possibly can. I've cleaned out my gut. I've cleaned up my home. I don't have any synthetic products. I'm not using any parabens or phthalates or sulfites, and I still have these symptoms, and they need very, very little hormones overall. Usually the less they need less. And we find that the more kind of, I like to use the word dirty, but the more kind of cluttered a diet is, you know, with smoking and weed and, processed foods and Doritos and, like all the good things, the more hormones those women tend to need. They do tend to need higher doses of hormones. And then so there's that. So we do gut cleansing and we do liver cleansing and we do genetic testing, and we help women find out what nutrigenomics are most optimal for them. We definitely do all of that. When it comes to the pseudoestrogens, those are kind of everywhere now. They're very pervasive. You know, it's the BPAs in plastic, which are acting as estrogens in our body. It's the Teflon on our cookware that's acting as estrogens in our body. It's different ingredients that are in the cleaning products that when they get consumed, they act as estrogen. And so it contributes to all of this endometriosis and adenomyosis and premenstrual syndrome and dense breasts and breast tenderness. And, young girls having their periods now at 9 and 10 and going through puberty at a very, very young age. So cleaning up that part of it can be very, very helpful in the grand scheme of things too. I use the analogy of if you have a leaky roof, you can kind of, you really need to replace the whole roof, but you can kind of patch the roof as you go until you're ready to replace the whole roof, because I think it can be overwhelming for women to be like, oh my gosh, I have to not only change my diet and exercise and take supplements and take hormones, I also have to change my cookware and I have to, and my sheets and my detergent and my soaps and my lotions and my creams and my face care. So, you know, usually we try to do one thing at a time and like, okay, we're going to fix this part of the roof, then we're going to fix this part of the roof. And then eventually you have a brand new roof.
Yeah, yeah, I think that's a good cliffhanger because I know you need to go. And can you just lastly, I could talk all day with you. You're so knowledgeable with all of this. Can you lastly just and you also do work with, you're not just with hormones and drugs and all this, you work with a bunch of naturals as well.
Oh yeah,
Herbal
yeah.
supplements and wild yam. I've had those questions. We touched on that last time, but some people were saying, hey, can you do it naturally? But the way that I explain it to them is that it's like for as deep as some women are already, it's like a grain of sand on a beach. It's really not going to
Move the needle.
move the needle.
Yeah. So definitely we meet women where they're at.
I love
And
that.
so I always try to like look at like the perimenopause and menopause time in a woman's life in a stage. So the earlier you come to us, like the earlier you are, usually if you're in a pre-symptom place, like you're not really having symptoms yet, you're just like, I'm 39 and I should probably talk to a hormone expert. I should get my hormones checked and maybe I should start doing some support. That's a great time to do herbs, diet, supplements, gut microbiome cleansing, all of the natural things, the wild yam cream, all of the natural things, because then you can push off and delay or maybe even avoid HRT altogether.
Yeah.
But if you come to us and you're 51 and you're having hot flashes and night sweats and insomnia and brain fog, you're probably going to need to start with hormones. Maybe we can clean up your diet and we can back you off and get you down, but you're probably going to need to start with hormones. And really what it is can women do it naturally? Yes, 20% of women can. Are you one of those women? We don't know because there's no predictive value other than if we look at your genome and your genetics, which, most women aren't interested in and don't want to do.
Yep.
We can't tell you, are you going to be one of those 20 women based on your lifestyle and, your diet and what's going on in your environment. So yes, you can. 20% of women can. That's kind of my answer. And 80% of women would benefit immensely. They don't need it. They can definitely go through perimenopause and menopause without it, but they would benefit immensely from the support.
So regardless where you're at, you're feeling some kind of symptoms, wherever you're at, you went to your doctor, you had that minimal, you're in the standard range, wherever you are, you're going to meet them there, take the blood work, take the microbiome samples, whatever package that they choose, and then you kind of bring them back one step at a time to do the base level. And if you're improving and you're good there and the blood work shows you're good, great. If you want more, and naturally, you said naturally women's ovaries start shutting off their hormones and that half-life menopause cycle. So naturally, no matter what, like you said, your husband said death is natural, right? And it's like, so no matter what, women are stuck in this spot where their hormones are declining and shutting almost off, even if they're normal and everything's all good. So you're just trying to replace that and keep yourself optimal up on that level. I love that you say that you meet people where they're at and then kind of walk them back and through that process. I think that's what a lot of women are looking for because they're so scared to interact with a hormone specialist or even get on a call or whatnot with you because they're scared. They don't know what it is or if they can afford it or where they go from there. With that being said, you said you provide a 10-minute consultation with anybody who is looking into your services as well, right?
Yeah. So our website is femgevityhealth.com and we provide a free 10-minute consultation so that women can have a totally non-obligatory place to ask questions and be like, this is what I'm experiencing and what I'm going through. Can you help me with that? And what are some things that you would do so that they can, understand what they're getting into before they pay money or sign up for something?
I love it. Okay. So if anybody wants to reach out, get that consultation, can you just put out your handles or you said before people can DM you if they have questions on Instagram or wherever you're at. Can you just throw those handles out there one more time and then we'll close this up?
Yeah. So the website is femgevityhealth.com and we're pretty much on all socials at FEMGEVITY. So it's just at FEMGEVITY. So that's YouTube, Instagram, TikTok, and we're on LinkedIn, Facebook.
You have a lot of free content. I went through and looked at all your free content, and it's you mostly speaking, and then your partner, Michelle. But it's really informational, and I've learned a lot just from going on there and screening and looking at what you were talking about on there. So that's really awesome. I'm so glad that you're out there doing this because we went through our own struggle for so long trying to we went through multiple companies and nobody, the minute we got on the call with you, and you started talking, explaining, I was on the other side going like, she knows what she's talking about. She knows she's going past my scope of knowledge. And I said, whatever it is, we need to hook up with her and get you, sorted out from ground level, ground zero.
Yeah, definitely. So
Awesome. All right. Thank you so much. We're definitely going to do this again because like I said, we can go down. I wanted to do so much more like always, but we can go down so many. I'm going to see what the reception is of this, and then we'll go off of those questions and maybe we'll do the next one off of that type of situation.
yeah, sounds great.
Thank you so much again. I hope you have a great day.
Yeah, thanks for the opportunity. I really appreciate
Absolutely. All right.
it. Okay, bye.
See you later.